I'll share the whiteboard right now. So let's say first case scenario, we have a 30-year-old woman. Okay, so this 30-year-old woman, she's coming with a presentation of, I'll just give an example that fishy smelling vaginal odor. Okay, so a 30-year-old, one second. So a 30-year-old woman, she is basically coming to the physician's office and her presentation is fishy smelling. Okay, there is fishy smelling of vaginal odor. So this itself is one clue. Second is they are saying that the patient is having a homogeneous gray white discharge. The patient is having a homogeneous gray white discharge. Okay, and they're also saying that the patient is also found to have a condition, okay, which is causing a decline in their vaginal hydrogen peroxide. Okay, a decline in the vaginal hydrogen peroxide producing lactobacilli. So they're asking what kind of organism this is and what is the characteristic of it. Okay, so this is going to be Gardnerella. So this is going to be Gardnerella. So the why am I saying this is a Gardnerella vaginalis? Because the patient is first of all having a fishy smell. Second, the patient is having a gray white vaginal discharge. Okay. So now with respect to vaginal discharge, you should know how to differentiate the conditions. Okay. So apart from the Gardnerella vaginalis, okay, we also have Trichomonas vaginitis and Candida vaginitis. Okay. So the Gardnerella is basically the bacterial vaginitis. Okay. The bacterial vaginosis. So Gardnerella, Trichomonas, and your Candida. Okay. So now I told you here the presentation is fishy odor. In your Trichomonas, they will give you anything from smell is going to be very foul smelling. Okay. It's going to be very foul smelling. And with respect to Candida, there is not much specific smell that they can give you, but they can give you like curd, like thick cottage cheese, like. Okay. So now they can give you the presentation of thick and it's going to be white in color and it's going to be curd like or cottage cheese like. So that kind of presentation will be given in the case scenario. Okay, so next is with trichomonas. You should remember trichomonas vaginalis. They're going to be having a foul smelling and they will have a yellow green discharge. They will have a yellow green discharge. And with your bacterial vaginosis, there is going to be a thin and a white discharge. Okay, the patients are going to have a white discharge here. Okay, so fishy smell, foul smell, no smell. Okay, white discharge, yellow green discharge, and white and cottage cheese like. Okay, this is white and thin and watery. Okay, but that is going to be cottage cheese like. So now this is going to be with respect to the presentation, like why the patients are having trichomonas and candida. They both have inflammation, but your Gardnerella doesn't have inflammation, and that's very important. And especially this trichomonas vaginalis inflammation, they have a strawberry cervix. Okay, they're going to be having the presentation of strawberry cervix. Okay, so the inflammation is present with your trichomonas and candida, and it is not present with respect to your Gardnerella. Okay, and these patients have strawberry cervix. So I gave you the case scenario of a vaginal discharge. What is the characteristic of the organism? Gardnerella is a gram variable. It's a gram variable organism. It's going to have pleomorphic rods. Okay, it's going to have pleomorphic rods. Okay, so please remember your bacterial vaginosis, that is your Gardnerella vaginosis, they are going to be a gram variable pleomorphic rods, and that is your fishy odor, and that is going to be having not no inflammation to be exact. Okay, so let's go to one more presentation that they can ask us with Gardnerella is what is the pH. Okay, so with Gardnerella they can question you what is the vaginal pH. So please remember vaginal pH is going to be more than 4.5. So next they will ask you what is your wet mount going to show. Okay, what is your wet mount going to show? Wet mount will be having clue cells in them. Okay, so please remember the differentiation. If the patients are having clue cells, then it is going to be your Gardnerella bacterial vaginosis. Okay, so please remember clue cells are very important. That is nothing but vaginal epithelial cells. Sometimes if they want to expand that and give it to you, it is nothing but your vaginal epithelial cells that is called as your clue cells. Okay, so something that is more than 4.5 clue cells are there and positive for your KOH test. Okay, so then that is treated by your metronidazole or your clindamycin is bacterial vaginosis. So now I'll go to the next question. Let's say we have a 20-year-old female. Okay, so she is basically coming to the clinic with all painful bumps that's seen in the right armpit. Okay, so now let's say that she's having painful bump. she's having painful bump and it's seen on the right armpit. Okay, so now you should remember that she was scratching her right arm like 5 weeks ago when she was trying to stop a fight between a dog and a cat. Okay, so she was scratching her right arm when she was trying to stop a fight between a dog and a cat. Okay, the physical examination is showing that there are so many multiple healed scratches that is seen on the right arm, and you're also seeing red papule that is associated with along. Okay, there is also a red papule that you can notice. There is also a red papule that you can notice associated with your scratch marks. Okay, so basically the scratch marks have been healed right now. Okay, so now we are checking in the same region for lymphadenopathies. There is small and tender lymphadenopathies. There is small and tender lymphadenopathies. Okay, so now this is a case scenario of a 20-year-old female who's coming to the presentation with to the clinic with your painful swollen bumps in the right armpit. So that she was scratched on the right arm 5 weeks ago when she was trying to stop between a dog and a cat fight. Okay, and then she's now having all that healed, but there is a red papule and the patient is having tender lymph nodes. So now if they ask you what is this whole presentation, okay, so this is nothing but cat scratch fever and short. Okay, that is nothing but your Bartonella henselae, because Bartonella henselae is anybody who's coming with an animal scratch and proximal lymphadenopathy. Okay, so please remember Bartonella henselae is going to be cat scratch fever, and that is going to come along with your chronic lymphadenitis. Okay, so that is also the cause for your bacillary angiomatosis that you see in your AIDS patient. Okay, so please remember, I'll tell few points about your henselae. So Bartonella henselae, the clue points that we have discussed in the class is anybody of cat's fever can have a chronic lymphadenitis. Okay, the patients can also have the presentation of bacillary angiomatosis seen along with your AIDS. Okay, and then the organism is going to proliferate into the lymphatic and blood vessels. So therefore, they have a mulberry lesion. Okay, they're going to have a mulberry lesion in the skin and in the subcutaneous area. Okay, Bartonella henselae is a small bacteria and it's going to be a gram-negative bacteria. It's closely related to your Rickettsia species. Okay, so that is very, very important with the presentation. Now coming on to the next case. So let's say we are having a 30-year-old woman. Okay, so she is nulliparous. She's coming to the gynecologist saying that she's having so much of anemia and so much of vaginal bleeding for the last, let's say, whenever she's having periods. Okay, so she's having a lot of vaginal bleeding during her periods, and she's also having anemia. So now her, let's say, physical attributes are 160 centimeter of height. Okay, weight is 59. Okay, weight is 59 kg and body mass index is 23 kg per meter square. Okay, so now you have to remember the bimanual examination was done for the patient, and in the bimanual examination there is normal adnexa. The patient is having normal adnexa. Okay, and the patient is also having enlarged uterus. Okay, enlarged uterus, and there is asymmetric contour. Okay, there is asymmetric contour. Okay, so now a case scenario where a nulliparous woman is coming to the gynecologist because of anemia and bleeding, vaginal bleeding, who's actually very tall. Okay, that is 160 centimeter for the weight of 59 kg. Okay, and the body mass index is 23. Bimanual examination is showing adnexa as normal, but uterus is actually having asymmetric contour with enlargement. So let's say we did an ultrasound now. Okay, because after bimanual examination, we did an ultrasound. So now ultrasound is showing a mass that is basically 5 into 4 centimeter that is seen in the submucosa of the uterus. Okay, so now this whole presentation why am I giving you is because they can ask you in this case scenario, the patient is coming with your leiomyomas only. If they give you a histology picture, they can give you like a fibroid. Okay, so please remember, leiomyomas are estrogen sensitive benign tumors that is going to be having enlargement of mass during your pregnancy. Okay, during your pregnancy, so don't get confused with this particular presentation and your pelvic. Sometimes, sometimes they can give you other infective cause case scenarios. For example, anybody who's having a pelvic inflammatory disease, they're going to be having a polymicrobial infection of your genital tract, right? So that's going to be seen usually like a after scenario of untreated sexually transmitted cervical infections. Okay, so they can't have a mass, they can't have anemia or vaginal bleeding. Okay, but this is going to be seen in the same middle-aged woman, pregnant woman, or non-pregnant woman. Okay, or a patient who's having ectopic pregnancy, or patient who's having additions. Okay, so same kind of case scenarios can be given. Okay, so this is a case scenario where during pregnancy you have an enlargement of the mass, that is your leiomyoma. Okay, so now we go to the microorganism. So let's say we have a 60-year-old female. Okay, this 60-year-old female, she is basically coming with the presentation of fever, night sweats, okay, and low back pain, and she's having joint pain. Okay, so fever, night sweats, low back pain, and joint pain, and she's basically frequently she's drinking unpasteurized milk. Okay, frequently she's drinking unpasteurized cow milk. Okay, which was basically bought from a person who is living in the Arizona Mexico border. Okay, they are living in the Arizona Mexico border. Physical examination is having a very, very strong and a moldy odor, like a body odor that you can appreciate. Okay, and the lymph nodes of both your axillary and cervical is enlarged. Okay, so now the liver is also enlarged. Okay, so these many clues you have. A patient of 60-year-old female coming with a 2 week history of fever. Okay, let's say the patient is also having night sweats and low back pain and joint pain. Unpasteurized cow milk consumption was seen. Okay, she's frequently taking that from a person who is living in the Arizona Mexico border. So now there is a moldy order, hepatomegaly, and your enlarged lymphadenopathy. So now they're asking you, what is this infection? So because it's an unpasteurized milk coming along with your contaminated livestock, and they have like a undulent fever along with your myalgia and arthralgia. The clue is brucella. Yeah. So this is going to be Brucella melitensis. Brucella melitensis is going to be a small. So Brucella melitensis is going to be a small gram negative Cocobacilli. It's very endemic to the Arabian Peninsula, India. From there to your Mexico, Central South America, everything you have to remember. Okay, if you can, please remember that contaminated livestock is how they're going to get it directly, or via the contaminated milk products you can get it. So they're going to spread via the lymphatics. So because they're spreading via the lymphatics, that's why your liver and your spleen gets affected. Okay, so either your contaminated milk products or contaminated livestock. So now please remember, in this whole brucella, you can go for your anti-lipopolysaccharide antibody titer. That is very good or effective method for the diagnosis of the same. Okay, anti-lipopolysaccharide antibody is an effective method of diagnosis. Okay, so now moving on to the next question. So let's say we have a 30-year-old man. Okay, so he is coming with the presentation of pain in the left testicle. Okay, there is pain in the left testicle. Okay, so now the pain basically, if a patient is coming with pain in the left testicle along with pancreatitis, I told you, along with orchitis, pancreatitis, and the patient can also have mumps presentation. Okay, mumps presentation with parotitis. Okay, so please remember that is one case scenario, but they can also give you, let's say, a pain in the left testicle and a 30-year-old man, and he's basically start this pain is basically starting after a morning run. Okay, and after running also it's becoming very progressive only, it's not controlled. Okay, so now the patient tried to ice the testicle, and the patient tried to, let's say, take acetaminophen for that. Okay, the patient tried ice and the patient tried acetaminophen. Okay, but the patient is not having like much of a relief, maybe minimal relief the patient is having. Okay, the patient is sexually active as well. Okay, so now on palpation, the testicle is very tender in the posterior aspect. Okay, the testicle is very tender in the posterior aspect. Okay, so now the question is, okay, so this tender testicle, okay, which is basically equal in size. Okay, so now the coughing is not worsening the pain. Okay, the coughing is not worsening the pain. Okay, so now the manual lifting of the scrotum is relieving some pain. Okay, major clue is manual lifting of the scrotum. Lifting of the scrotum is relieving the pain, so this you might study only in the reproductive chapter, like what this actually means. So this is called as your Prenz sign. Okay, a patient who is basically having case scenario where a 30-year-old sexually active coming along with pain in the left testicle, tried eyes and acetaminophen. It's giving a very minimal relief. Right now, having mild erythema and a posterior tenderness in the testicle, and the coughing is not worsening the pain, and the manual lifting of the scrotum is relieving some pain. So that is your manual elevation of scrotum is relieving the pain is French sign, and this is epididymitis. Epididymitis is basically which two bacteria? Can anybody guess?
Chlamydia trachomatis and Neisseria gonorrhea.
Yeah, so it's going to be chlamydia trachomatis and Neisseria gonorrhoeae. So anybody who's having a localized, a unilateral, a testicular pain, okay, so which is usually relieved by manual elevation, okay, which is usually relieved by manual elevation, okay, and they will have a normal cremasteric reflex. Okay, please remember, and they will have a normal cremasteric reflex. This is going to be your epididymitis, which is your Neisseria gonorrhoeae or Chlamydia trachomatis. These are two causes that you have to remember. Okay, so now the sometimes the epididymitis, which is basically can progress to have a scrotal swelling and erythema. Okay, so they can progress to have a scrotal swelling and erythema. Okay, that is also quite normally seen. And they will ask you this cremasteric reflex, what is the root value, and they will ask you if it is normal seen along with your pain, what condition is that? So that can be one more clue that they can ask you. So let's go to the next question. We have a 30-year-old woman. So she's basically coming with fever and let's say excruciating abdominal pain. Okay, so she's having fever and excruciating abdominal pain. So now they tried OTC, over the counter medications like NSAIDs and everything. It's not relieving the pain. Okay, so she's having a history of IV drug abuse. Okay, she's having a history of IV drug abuse, and we did a pelvic examination for her. The pelvic examination is showing that there is purulent discharge. Okay, there is purulent discharge. Okay, and next is they're also saying that there is cervical motion tenderness. There is cervical motion tenderness. Okay, so now a patient who is having your fever and excruciating abdominal pain, and they have tried NSAIDs and the NSAIDs are not working out. She's an IV drug abuser coming with a purulent discharge, and there is cervical motion tenderness. Okay, so what is this term telling us? The patient is basically having PID. Okay, so pelvic inflammatory disease. So now I'll add on to the case scenario. The leukocyte count is like 14K. Okay, so let's say we have your aspartate and alanine transaminase values as 19 and 11. Sorry, 17. Let's see. Let's keep. Okay, so basically there's a PID case scenario. But what is the complication of PID, which is going to come and present as a abdominal pain, which is seen along with your IV drug abuse, and it's going to be very excruciating. So the complication of PID, we do know it's a pelvic inflammatory disease, and I've discussed about the bacteria of it. Okay, so please remember that polymicrobial infection of your female genital tract, like it's usually your Chlamydia trachomatis and Neisseria. Neisseria itself is there, but this PID we have discussed with relation to scarring of your fallopian tube and ectopic pregnancies. And now you should remember this PID can also cause your Fitz-Hugh-Cutis syndrome. So Fitz-Hugh-Cutis syndrome is nothing but perihepatitis. Okay, so the PID can have a complication of. So this is going to be a perihepatitis. That's why the patient will usually come with a right upper quadrant pain, which is usually very sharp, okay, apart from the conditions of your PID, okay. So this is going to have a right upper quadrant pain plus your classical PID case scenario where the fever, abdominal pain, and vaginal discharge usually comes, okay. But usually you can look for the word cervical motion tenderness, okay. So the only reason is because the liver enzymes will be normal. So I gave you the liver enzymes because liver enzymes will be normal. Just the liver capsule alone is going to be involved. That's why you have pain. Okay, just the liver capsule alone will be involved. Liver is not fully involved. The liver enzymes are going to be normal. So it is only perihepatitis. Please remember your Fitz-Hugh-Cutis, which is a complication of your PID, is perihepatitis. Enzymes will be normal. Okay, sharp abdominal right quadrant pain will be there because of the capsule involvement. Okay, so now we'll go to the next question. So let's say we have a 20-year-old woman. She's basically coming to the emergency department with the presentation of acute abdominal pain. Okay, so this acute abdominal pain is seen in the right lower quadrant. Okay, it's seen in the right lower quadrant. So now on examination, she's having this abdominal pain with both your rebound and godding. Okay, there is rebound and godding. Okay, so the beta HCG level in her is basically elevated. The beta HCG level in her is elevated. Suppose if I didn't tell you this, if I just change this acute abdominal pain which basically started from periumbilical and went to your right lower quadrant, then it's going to be appendicitis. Okay. Suppose if I didn't tell you that, okay, periumbilical to right lower quadrant is not given, but I'm telling you beta HCG is high, then it becomes an ectopic. So ectopic means maybe the patient had a PID before. Okay. So now otherwise, if they are giving you the acute abdominal pain and they are just changing this whole case scenario that they are coming with right upper quadrant pain, okay, and they are saying that right now the patient is basically having a drainage into the right upper quadrant area, or there is a fistula presentation, or they're giving you a histological picture of lymphoid aggregates, okay, lymphoid aggregates, that is going to become your Crohn's. Okay, so please remember acute abdominal pain here, just because I told you the beta HCG is high, it's going to be your ectopic pregnancy that is going to be seen along with your PID. Okay, so now the question is again with respect to microbiology, they will ask you what is the organism causing PID. That is again your Chlamydia trachomatis. We've already discussed about that. Okay. So moving on to the next question. So let's say we have a patient of 10-year-old boy. Okay, 10-year-old boy, he's basically coming with his mother because he's having a right leg pain. Okay, he's having a right leg pain. Okay, the patient says that it has been very difficult for him to put that weight on that leg. Okay, and he's also having a history of sickle cell disease. So right leg pain, sickle cell disease, what was the organism that you have to think about, as I told you?
Cinderella, ma'am.
Yeah, so you have to remember osteomyelitis is okay. A patient who's having osteomyelitis in sickle cell disease, you have to remember encapsulated organisms. And encapsulated organisms are going to be your Salmonella, E. coli. Okay, so because the usual thing is they lose their splenic function. Okay, they are going to lose the splenic macrophages. So the encapsulated organisms are not going to be destroyed. So that's why after splenectomy, we give vaccinations. Okay, so the pneumococcal vaccinations, and usually the vaccinations are given and antibiotics are given. Otherwise, the patients are going to have osteomyelitis. But here the question is not that. Here the question is what is the virulence factor that is going to predispose to this current infection? So now you know that it's usually the salmonella as a common factor whenever the patient is having your osteomyelitis and sickle cell disease. Okay, what is the virulence factor of your salmonella or of the bacteria that is basically invading? So you have to remember all that is capsule. The virulence factor is capsule because they have capsule only, it's not being destroyed. That is all the Salmonella, E. coli, Streptococcus pyogenes, okay, all are the causes of osteomyelitis plus sickle cell disease. Streptococcus pyogenes also. Okay, osteomyelitis plus sickle cell disease, okay, because the bone culture is also going to show you gram-negative bacteria. Okay, so then it's going to be either your Salmonella or E. coli. Okay, so next case scenario, let's say we have a 30-year-old man and they are coming with your painful ulcer. So this painful ulcer is there on the shaft of the penis. Okay, shaft of the penis. Okay, the patient is also reporting to have like several sexual partners over the past years. Okay, and the physical examination is also showing the same ulcer as 1.5 centimeter of ulcer with the erythematous base and clearly demarcated borders. Okay, and now when we looking into your ulcer, the base is also bleeding whenever when you scrape it. Okay, the patients, so this much of information they're giving about ulcer, but nothing is useful for and right. So the patient is having left side inguinal lymph nodes that are also swollen and tender. Okay, these left side inguinal lymph nodes are also swollen and they are tender. Okay, so now on palpation. Okay, and they're having purulent discharge. So now what is going to be the organism and the characteristic feature of that? Painful ulcer, painful swollen lymphadenopathy with a purulent discharge is what organism?
Herpes, ma'am.
Ducrei. Herpes is going to be, they don't have a purulent one. The others are same. Okay, if it is purulent, it is Ducrei. Cancroid, you have to remember. If it is not purulent, you have to remember the same painful ulcer, painful lymphadenopathies is herpes simplex virus 1 and 2. So now here with respect to cancroid is STI who is coming with first they will start like a painful genital ulceration. Then they become a purulent inguinal lymphadenopathy. It is a gram-negative coccobacilli organism, gram-negative coccobacilli organism, and it's going to be cancroid Haemophilus ducreyi. So now I have discussed about this. I will write it again also. So let's say we are having a patient who is having purulent versus non-purulent. Non-purulent means we have so many examples for that. Like for example, herpes simplex 1 and 2. Okay, your treponema pallidum, this is all non-purulent. Okay. Suppose if they're talking about painless ulcers, okay, painless ulcers, or they're talking about painless papules, okay, painless papules, okay. So you should remember one of the other example is also chlamydia. Chlamydia trachomatis is also painless ulcers, okay. So the ulcers and lymphadenopathy, which is painful or not, I've discussed about this before. Please remember all those varieties. So 30-year-old man. So
Excuse me,
let's say,
ma'am.
yeah,
What about Klebsiella, ma'am?
in this case scenario, no,
Ma'am,
Klebsiella will not
painless ulcer or painful ulcer?
come again. Da.
Painless ulcer or it is painful ulcer, ma'am?
No, it's not painful. Only your case scenarios with respect to your Haemophilus ducreyi or your herpes simplex viruses you have to remember. So Klebsiella is not a very common organism that they will ask you with the ulcer presentation. So Klebsiella, they will ask you like an alcoholic or a diabetes presentation who's coming with a pneumonia, or they can ask you with respect to like a third infection that you have to remember, like a third cause of UTI, third cause of pneumonia, like that. So if they are giving like a specific case scenario, then they will ask you. Usually with respect to ulcers and lymphadenopathies, you have to differentiate between your syphilis, ducreyi, herpes simplex viruses, and chlamydia and Neisseria. So these are the 5 organisms that they will keep shifting it out with respect to the answers. So now next question. So let's say we have a 30-year-old man. Okay, 30-year-old man is basically coming with worsening of cough and headache. Okay, 30-year-old man. So he's coming with worsening of cough and he's also having headache. Okay, so now he's basically working at a commercial factory. So they have given you a case scenario of slaughtering process. Okay, there is a slaughtering process, and this process is basically slaughtering of chickens only. And he's having cough and headache. He's working in this factory, and his headache is always intensifying whenever he is looking at bright lights. Okay, whenever he is looking at bright lights. So now you should remember that in the X-ray finding, the patients are going to be having diffuse infiltrates of right lung parenchyma. Okay, they're having diffuse infiltrates of right lung parenchyma, okay. So now you should remember that in a 30-year-old man who's coming with a cough and headache, okay, he's working in a commercial factory of slaughtering the chickens, and his headache is getting very or worse or intensifying with your bright lights. Okay, the temperature is all fine, like say temperature is 101. Okay, so let's say the patient is also having like a pharyngeal erythema along with that. Okay, so chest X-ray is also given with your diffuse infiltrates of right lung parenchyma. So in these kind of case scenarios, you have to remember what is the infection that's going to be on the occupational exposure of birds or chickens.
Chlamydia psittacosis.
Yeah, so this is going to be psittacosis. So psittacosis is occupational exposure to chickens, and it's not just chickens, parrots, cuckoos, turkeys. Okay, so any outbreak with respect to a bird. Okay, so the chest X-ray is also trying to show you unilateral lung infiltrates. Okay, so now moving on to the next question. Let's say we have a patient with a 47-year-old woman, and she is coming with, let's say, chlamydia psittacosi itself. Okay, the psittacosi chlamydia presentation is given to you. So now they're asking exposure to which they can ask you the other way also. Like the previous case scenario, I gave you the birds and I asked you about the disease. Now I can give you the disease and I can ask you about the exposure. Okay, so now moving on to the next question. So let's say we have a 30-year-old man. 30-year-old man, he's basically coming with right arm pain. Okay, so apart from the right arm pain, he's also have feeling very feverish. Okay, so now he's also having erythema, swelling in the same area. So fever, erythema, swelling, everything there on the right arm. So we did a MRI to understand about the soft tissues. So the soft tissue and the bone both are inflamed. Okay, both are inflamed. Both the soft tissue and the bone is inflamed in the right humerus area, in the right humerus area. Okay, so now what we did is we did a blood culture of the organism and the bone biopsy of the patient. Okay, blood culture is showing that it's a aerobic bacteria and it is a gram negative bacteria and it is a oxidase positive rod. Okay, aerobic bacteria, gram negative bacteria, oxidase positive rod, and it's also bone biopsy picture also. Let's just say that they are giving it to you. So now they're asking you what is the strongest risk factor for this patient's likely presentation of your, maybe you guys can tell one by one. What is the diagnosis? Second, what is the organism? Third, what is the risk factor? Okay, 30-year-old patient coming with a right arm pain, erythema and swelling, soft tissue inflammation, bone inflammation, and right humerus it is seen. And the organism is aerobic gram negative oxidase positive rod. Anybody want? So this is
Pseudomonas.
going to be Pseudomonas aeruginosa. And apart from that, you should remember this osteomyelitis. So osteomyelitis caused by Pseudomonas aeruginosa, what is the major risk factor? For especially this particular presentation is going to be all the catheters, your injectable drug use, your hemodialysis. Okay, so your sickle cell disease, you have a lot. You have to like pick it up in the options in whatever they have given it to you. Okay, so usually when we have a gram negative oxidase positive rod, I'm going to be thinking about Pseudomonas aeruginosa, or unusually you can also think about like Pasteurella and Vibrio. Okay, but Pseudomonas is not the most common cause of osteomyelitis. It is only seen in a IV access, like an injectable drug use or a intravenous access patient. Okay. So now moving on to the next question. So let's say we have a patient of 30-year-old man. So this 30-year-old man, he's coming to the clinic with fever and fatigue. Okay, he's having fever and fatigue. Right now, he went for a camping trip, and the camping trip was in Arkansas. Okay, and there was a tick that was attached to the skin for like 2 days since the patient basically returned back home. Okay, so now he has developed like a small itchy bump in that site. Okay, so he has developed a small and itchy bump in that site. Okay, so now on examination, what we're finding is on evaluation. So the patient is having like a very well demarcated and it's a tender papule. It's a very tender papule, and you're also seen to have that there is a black eschar near his popliteal fossa. Okay, there is a black eschar that you can appreciate near the right popliteal fossa. Okay, right popliteal fossa. So now right linguinal lymphadenopathy is also seen along with it. Right linguinal lymphadenopathy is also seen along with it. And the sample of the microscopic evaluation sample was taken out from the ulcer. Okay, and it's showing that it is an intracellular organism and it is a gram negative organism and it's a Coccobacilli. Okay, I'll just repeat the case. A 30-year-old man went for a camping trip. Right now, he's having fever and fatigue after the camping trip, and the tick basically attached to his skin for 2 days, and there is a red, bumpy presentation that can be appreciated in the same area. So now this is a very well demarcated tender papule. Black eschar is there near the right popliteal fossa, and the patient is also having right inguinal lymphadenopathy, and it's an intracellular gram negative Coccobacilli. Okay, intracellular gram negative Coccobacilli. So can you guys guess what organism this could be? So this is a case scenario of a patient who's having Francisella tularensis, because Francisella tularensis will have a well demarcated lesion with a black base, and it's usually spread via your tick. Okay, so I think tularensis is not explained very detailedly and all. They would have just given it as one or two lines in a tableau column. Okay, so please remember tularemia is either your ticks or rabbits or deer flies. They will not give you rabbits all the time. So please remember it's either your ticks or rabbits or deer flies. Okay, deer flies. So now with respect to your tularemia, they can give you a case scenario of patient who had a tick bite in an endemic area, now coming with a glandular tularemia, that is basically via the animals or the flies, okay, and it's transmitted, and it's very common in the continental US, predominantly in the Midwest and the Southeast, okay. So now going on to the next case scenario, we have a 2-year-old boy. So this 2-year-old boy, he's attending a daycare. Okay, he's attending a daycare and he's brought to the office because of low grade fever, and he's also having poor oral intake. Okay, so now physical examination is basically done, and the physical examination is showing that there is erythematous pharynx. Okay, and the patient is having this erythematous pharynx seen along with vesicles. Okay, and the patient is having shallow ulcerations. Okay, there are shallow ulcerations that you have to know. Okay, shallow ulcerations are seen on the palate. Okay, so the patient is basically so you can tell me the diagnosis if you guys know. Otherwise, the patient is diagnosed with Coxsackie virus. Okay, so now the question is, which part of the body, with respect to your hand or foot or cranial nerves or your large joints or testicles, which part of the body is going to be involved with your Coxsackie that you know of?
Hand and foot.
Yeah, it's going to be hand, foot, mouth disease. So you should remember Coxsackie virus, when a patient is going to be coming along with this presentation, it's a hand, foot, mouth disease because it's Coxsackie virus A or enterovirus 71. Two presentations are there, Coxsackie A or enterovirus 71. They all come with a fever and a vesicular or ulcerative lesions that can be seen around. And because the presentation is very small, that's all. You just have vesicular or pustular maculopapular lesions on the hands and fingers and soles. Okay, so now going on to the next question. So let's say we have a 20-year-old boy. So he's basically coming with recurrent bouts of dizziness, and he's also having recurrent bouts of palpitations. Okay, recurrent bouts of dizziness and palpitation. So basically, he started with like an intermittent joint pain, okay, in the intervening days. And right now, he's also having a AV block, a cardiac strip of AV block is given. Okay, so now the patient is also having uh, let's say the patient is also having a rash that is seen on the trunk. So now what is this condition?
Lyme's disease.
Lyme's disease. This is going to be a patient who's having AV block. Your rash is going to be on the trunk, that is your bull's eye rash. Okay, and the patients can have cardiac disease, anything, myocarditis, conduction disturbances. It's going to happen like 4 to 6 weeks later, your entire presentation. So please remember Lyme's disease, they have given beautifully in the first aid itself with respect to 3 presentations. Okay, so now let's say in the starting, they just have your bullseye, erythema migrans. Not see erythema, there are so many presentations. You have nodosum migrans. You please remember the differences. Okay, so erythema migrans is bullseye. Okay, they have, that's your stage one. Stage two is facial nerve palsy. Okay, and your AV block that you can remember, basically cardiac presentations and facial nerve palsy. Okay, and stage three is when they affect your joints and the neuro. Okay, so chronic arthritis and your neuropathies and your encephalopathies is going to be there. So please remember the treatment, if it is a pregnant patient or if it's a child who's less than 8 years, what is the drug that we have to give?
Amoxicillin.
Amoxicillin, right? So doxycycline is a first line treatment, but if it's a pregnant patient or less than 8 year old, you have to give amoxicillin. And suppose if you have to go for an IV therapy, what is the drug that would have been preferred?
Ceftriaxone.
Okay, fine. Ceftriaxone. Okay, so
Ceftriax.
we'll move on to, yeah. So we'll move on to the next case scenario. So let's say we have a patient who's coming along like a 55-year-old man. Okay. So he's coming with a lower back pain. Okay. And he's having this presentation of 99 degrees of fever. Okay. And he's living with HIV and he's living with AIDS. Okay. So lower back pain, fever, HIV and AIDS. Okay. So HIV and AIDS, you should start thinking why a HIV patient will have fever. What all infections can you think about? So he is saying that he had a lung infection like several years ago. Okay, but right now he's not taking any medications for that or this. Okay, so right now his major presentation is your tenderness in the lower back. Okay, so the range of motion is decreased, the paresthesias are there. Okay, So because of this, the range of motion is decreased. Okay, the patient is also having paraspinal, means nearby spinal area. You're having paresthesia. So that is a major presentation. So we took an X-ray. X-ray is showing in the L4, L5 regions. There is osteolytic lesions. There is osteolytic lesions, and there is abscess that is seen in this particular area. There is abscess at L4 and L5 demineralization, and osteolytic lesions are seen. Okay, so and then they're also giving you a chest X-ray finding of your entire lung presentation, or maybe the just a common scenario. Okay, so now here they're asking you what is the cause of the lower back pain. So what is going to be the cause of lower back pain in a HIV patient?
Heart disease,
Yeah, so it's going to be tuberculosis that is going to be causing your POTS disease, TB spondylitis. Okay, so you should remember tuberculosis is basically a patient who's coming with your presentation of cachexia. Apart from that, no, I'm not talking about the lung presentation. I'm talking about general outlook of the patient, like an immunosuppressed patient in untreated HIV and cachexia. So they're going to be having degenerations and abscesses that is going to be noticed in the X-ray. So the patients are going to be having your TB spondylitis. TB spondylitis is your POTS disease. So the mycobacteria is going to spread hematogenously to the vertebra of the spine. Using usually the lumbar spine is what it's going to affect. Okay, so now moving on to the next question. So a 30-year-old man, okay, so he is coming with the presentation of tender bumps. Okay, they are saying that the patient is having tender bumps. Okay, so now that's basically there on the groin for 2 days. Okay, he had an unprotected sex with both men and women. Okay, he had an unprotected sex with both men and women. Okay, so when right now they're saying that the ulcer is painless on the penis. Okay, the ulcer is painless on the penis, which is basically resolving on its own. Okay, but right now the patient is coming with a bilateral presentation of a tender inguinal lymphadenopathy with a 2 centimeter ulceration on that itself. Okay, and the patient is having this on the left side. Okay, so the patient is having a bilateral tender inguinal lymphadenopathy with 2 centimeter overlying ulceration in the left side. Okay, so now what is going to be the organism here? So this is a with even if you didn't read all of these things, if you remember the word of tender bumps that's given in your first aid, then also you can find out it's your lymphogranuloma venerum. Okay, so the tender bumps, or let's just say small painless ulcers on the genitals, then becoming a painful inguinal lymph node that is ulcerating, that is your buboes. Okay, so something that is becoming an lymph node and ulcerating after a painless ulcer, you have to remember buboes. You have to treat with doxycycline. It's going to be your L1, L2, L3 type of lymphogranuloma venerum. So lymphogranuloma venerum, it's usually commonly seen in heterosexual people. Okay, and it's also seen in homosexual as well. The first stage is painless, then you have a painful, that is very, very important, and the time between these both is 4 to 6 weeks. Okay, you have like a 1.5 month time period between that. So this bilateral inguinal, the bulge that you see, right, this whole thing, this is called as group sign. This is called as group sign. They will not ask you fancy names, signs and all, but I just thought you guys should know this is called as group sign. And in the late stages only, the lymphogranuloma venerum, they can cause like a fibrosis and stricture of your anal tract. Okay, so what all in the late stage of lymphogranuloma venerum, what it's going to cause is you have fibrosis. They can cause strictures, they can also cause strictures, and they can also cause infertility, and they can also cause elephantiasis. Okay, they can also cause elephantiasis. Okay, so elephantiasis, infertility, fibrosis, strictures, all are going to be seen with your late stage of lymphogranuloma venerum. Okay, so now going on to the next question. So let's say 50-year-old woman is there. Okay, so she's coming with a 2 day history of vaginal irritation. Okay, so she's having 2 day history of vaginal irritation, and it is foul smelling, and it is gray in discharge. Okay, and the patient has gone to a physician, and the physician has already given an antibiotic. So after taking the antibiotic, the patient is drinking alcohol. Okay, so now the patient, after taking the antibiotic and then drinking alcohol, she's having nausea, vomiting, headache. So what is basically happening? Which molecule is causing this particular presentation? Or you guys can tell me what is the diagnosis with respect to micro, and then we'll go to the antibiotic and the adverse effect. So what is the diagnosis here?
Trichomonas vaginalis.
This is just a case scenario of bacterial vaginosis, even though they have given a foul smelling, no, they have given a gray discharge. Okay, so that is just a way to confuse you. So sometimes they can just put the vaginal discharge as a foul smelling as well. Okay, because they have given a gray discharge and not a green color discharge. So we have to choose your bacterial vaginosis here and not your trichomonas. So again, I'm saying like with respect to USMLE question pattern, they will give you two scenarios, like it's overlapping with respect to symptoms. Okay, they will do it purposely to confuse you. I will always want you guys to look at the specific finding for that particular organism, or a histological finding, or a lab finding, okay, which is specific for to that. Okay, so please remember that. So here, bacterial vaginosis is treated with metronidazole. So what happens when you take alcohol and metronidazole together? So that whole thing is called as, yes, disulfiram like hangover reaction. That's why the patient is having nausea, vomiting, you can have flushing, you can have palpitations, you can have headache. Okay, so the patients here, the question was, what is the molecule that is causing it? Okay, the molecule that's causing it is acetaldehyde. Okay, you should remember the whole alcohol metabolism. Okay, the concept is nothing but your ethanol, it's using your alcohol dehydrogenase. They're going to become your acetaldehyde. Okay. So now this is going to require, I think, one NAD plus here. Okay, which is going to become NADH. Okay, and you should also remember the ethanol to your acetaldehyde is also going to require two other steps that you have to know along with this. Okay, one is your catalase. Another is your CYP2E1, CYP2E1. So here also you have your NADPH being used, and here your H2O2 becomes water. So this reaction is there in the first state. But what is important is ethanol is becoming acetaldehyde, and this acetaldehyde is only becoming acetate. Okay, so now you have to remember this acetaldehyde is what is very uh, worrisome, because it's going to cause all these symptoms. Whatever hangover symptoms that your eyes have, it's usually acetaldehyde, and that causes nausea, vomiting, flushing, headache, chest discomfort, abdominal discomfort. Okay, that's very important. So the acetaldehyde dehydrogenase inhibitors are only your disulfiram. Okay, so this can be seen with other drugs also. The effect can be produced even with chloramphenicol. It can also be produced with cephalosporins, certain cephalosporins alone. Okay, so they can ask you along with that. So moving on to the next question, let's say we have a patient who is 25-year-old and it's a sexually active woman. Okay, so now she's coming to the gynecologist because they're having foul smelling discharge, but they're telling you on the wet mount it is showing clue cells. Okay, so now they're asking what is the antibiotic mechanism? What is the mechanism of the antibiotic that is given for this patient? Okay, so my options that I'm going to give you is, I'll make it easy, the options. Okay, so let's say either is it a patient who's having antibiotic that is blocking your cross-linking of your cell wall? Is it blocking your cross-linking of cell wall? Or is it going to be formation or binding with your d-ala component? Okay, or is it going to be forming your free radicals that is damaging your DNA? So which is going to be the answer? That is your clue cells. What is the diagnosis here?
Bacterial vaginosis.
So it is bacterial vaginosis. The patient is on metronidazole. Metronidazole is going to inhibit cross-linking or d-ala sequence, or is it going to be free radicals? It's free radicals. Okay, cross-linking is basically your penicillins, and your d-ala sequence is vancomycin. Okay, 30 years, 50 years we study, that is your tetracycle, and then you have your chloramphenicol, and then you have your macrolides, 30 and 50s. Okay, and then you should remember your free radicals is metronidazole. Okay, so now moving on to the next question. So let's say we have a patient who's coming along with 30-year-old woman. Okay, so she's coming because 1 week she's been having this vaginal itching and discharge. So this vaginal itching and discharge, right now we collected the fluid, and it's showing that the discharge is frothy and it's greenish blue in color. So it's greenish blue in color. So now they're asking you, when you do a light microscopy of this, what is the organism characteristic that you can actually notice in this particular case scenario? So first you guys tell me greenish blue is trichomonas, right? So greenish blue is trichomonas. So I'll give you four options. Tell me which is trichomonas here. So let's say we have a flagellated organism. First option is flagellated organism on the wet mount. Second is a patient is having fussy epithelial cells. Okay. So the patient is having, second option is, sorry, fuzzy epithelial cells. Third option is gram-negative diplococci that you will be seeing on a gram stain. Or fourth option is gram-positive rod that you can see on the gram stain. Or is it a pseudo-hyphae and your spores that is seen on a Giemsa stain? Okay, so which is your trichomonas in this?
Flagellated.
So flagellated organisms are going to be trichomonas. The reason I wrote others is to discuss it as well. Fuzzy epithelial cells, clue cells, that is your Gardnerella. Okay. So your gram-negative diplococci related along with this whole presentation of, I think, cervical collection of fluid and, adnexal tenderness, vaginal discharge I was discussing about. So sexual infections that you can remember gram-negative diplococci is Neisseria gonorrhoeae. Gram-positive rod is lactobacilli. Okay, just one example I'm giving. Okay, and your spores and pseudo hyphae on the Giemsa candida albicans, they have cottage cheese-like discharge. Okay, so now next question is, what is the vaginal pH when a patient is having candida infection?
4 to 4.5.
Yeah, so it's going to be 4 to 4, 3 point, that alone check in the U world. There were two variation of values between the 2020 edition and 2022 edition. So one book was saying 4 to 4.5, another was saying 3.8 to 4.5. So the best is if you have a variation in values, which will happen like very frequently. Whatever the NBME is saying you, that is your right answer in the exam. Okay, so NBME keeps updating like every now and then. So whatever your NBME is saying is the right answer. So next is 30-year-old women. Okay, so now let's say she's having a follow up in the clinic because then at the last and appointment she went for a pap smear, like a pap test. Okay, and she ordered also did a cervical biopsy, and both of them have revealed that it's a high grade cervical intraepithelial neoplasia. Okay, so now they're asking what is the pathology that is going to be seen in this whole presentation? The CIN, this is your high grade CIN means CIN3. Okay, that is your cervical intraepithelial neoplasia, third type. Okay, they're going to have this plastic. So the question is, which virus is going to cause this? What the features of it?
Papilloma
Cervical
virus.
is going to be, yes, human
It's
papilloma virus. So human papilloma virus is going to be one risk factor. Okay, but they would have given you in the first aid that if a patient is having a immunocompromised condition, even your HIV, that is your HIV or transplant, okay, that is also a risk factor for your dysplasia and carcinoma in situ. Okay, that is very important to remember if a patient is having your HIV, that is immunocompromised conditions. Okay, so with respect to sexually transmitted infections, okay, I'll tell you certain features. You guys are going to guess it. Okay, so if a patient is going to be coming with buboes, if a patient is coming with buboes, that is a painful lymphadenopathy which is able to ulcerate. I told you this is lymphogranuloma venerum. This is lymphogranuloma venerum. But if they are a patient who is basically coming with a painless presentation of a beefy red tongue, okay, like a beefy red ulcer, okay, so painless beefy red ulcer that is bleeding very easily whenever it's coming in contact. So what is that condition or organism known as?
granuloma inguinal.
So this is going to be granuloma inguinal. Okay, the two granulomas you have to know is lymphogranuloma venerum, granuloma inguinal. Okay, so this is going to be either a patient who's coming with your Klebsiella, okay, or a patient because Klebsiella is Calymatobacterium granulomatosis. Okay, the full form of it. Okay, your Calymatobacterium. So they have like a Donovan body that you have to remember. They have Donovan body that you have to remember. They have painless ulcer, they're going to have beefy red ulcer, and they're going to be seen with a Calimatobacterium granulomatose. Okay, so that's going to be your Donovan bodies. That is staining that when you do a staining, you can actually notice that. Okay, so the two granulomas I wanted to discuss. So now going on to the next question. So let's say we have a patient who is a 10-year-old boy. So he's basically coming with a rash. It started on the wrist and ankle. Okay, it started on the wrist and ankle, and then it went for the palms and soles and then trunk. Okay, so this is a course of the rash presentation. So he went for a trip in North Carolina. Okay, so he went for a trip in North Carolina, and 14 days ago he went. Okay, and when he returned back 7 days later, he's been having this headache and he's also having this mild fever. Okay. So when we looked into the physical examination, you can appreciate this whole rash that I told you in the wrist, ankle, palm, and trunk. So what do you think has happened in that trip? And now that the patient is coming with all eruption of red macules and papules, which is looking like a petechee in the entire body. So this is going to be Rocky Mountain spotted fever. Rocky Mountain spotted fever is your rickettsia rickettsii that's going to be transmitted via your dermacentor ticks. Okay, so your Rocky Mountain spotted fever is going to be your rickettsia rickettsii, and the patients are going to be transmitted. This transmission is your derma center ticks. Okay, especially it's going to happen via your camping trips. Okay, trips. You have to remember that these patients are going to be having a general viral presentation. So now 50-year-old man. So let's say 3 days he's been having this presentation of fever and chills, okay, and lower back pain. So now we saw a history of IV drug use. Okay, we also saw a history with a temperature of 101. Okay, the lumbar spine, when we try to palpate, it's very tender. It's very tender. So now here we should know what is the bacterium that you can recover from the blood culture. Okay, so what kind of characteristic is it going to be? Is it a gram positive, negative, or is it a patient who's coming with coagulase positive or coagulase negative or catalase positive or catalase negative? So fever, chills, lower back pain in a 50-year-old, we should think about osteomyelitis. Osteomyelitis, since they haven't given any specific cause scenarios, we can still go for Staph aureus. And Staph aureus is a gram positive bacteria, catalase positive bacteria, coagulase positive bacteria. Okay, so you have to remember all the characteristics because only for step one it is needed. For step two, you'll not come across. So 30-year-old patient, let's say we have a male. Okay, so this time he's having like so many sexual partners. Okay, he's having multiple sexual partners, and he is coming with a presentation of painless, itchy perianal lesions. Painless, itchy perianal lesions. Okay, so then we did ELISA. The ELISA positive for HIV. Okay, so now the patient is having a painless, itchy perianal lesions, and the ELISA was done and it was positive. So now they're asking us what is this whole presentation, or maybe I'll tell you. The presentation is white, okay, and it is hyperkeratotic, and they basically have very aqueous appearance. So this is a case scenario of condyloma acuminata. Condyloma acuminata is anogenital warts. So that will be coming with a white, hyperkeratotic, very aqueous appearance in a sexually active patient, or especially immunocompromised patients. So HPV is a cause of your condyloma acuminata. So that is very, very important because there are two HP stains, the types that you have to know, 6 and 11. Okay, both of them are actually the common subtypes associated with your warts in the anogenital area. So you have to remember that. Okay, so I think that was bacteriology. So today evening when we are discussing, I want you guys to prepare virology and come. Virology will be longer class. Okay, thank you guys.